JAK inhibitor therapy in a child with inherited USP18 deficiency. Definition: deficiency of ubiquitin-specific peptidase 18 USP18 is a severe type 1 inherited.
Mechanism of action of JAK inhibitors. The Janus kinase or JAK protein family consists of JAK1, JAK2, JAK3, and tyrosine kinase 2 or TYK2. They interact with the intracellular portion of cytokine receptors and play an important role in the signal transduction pathways for multiple cytokines, including pro-inflammatory cytokines such as interleukin-2 or IL-2, IL-4, IL-7, IL-9, IL-13, IL-15, IL-17, IL-21, and IL-23, which are involved in the pathogenesis of IBD. JAK1 and JAK3 modulate an adaptive immune response via IL-2, IL-4, IL-7, IL-9, IL-15, and IL-21 signaling. JAK proteins are associated with distinct cytokine receptors, but initiate their transcription response via common intracellular signaling pathways. Physiologically, a cytokine binding to its specific cell surface receptor initiates a conformational change in the receptor that in turn leads to recruitment and activation of the associated JAKs. Activated JAKs then phosphorylate specific residues on the intracellular domains of the cytokine receptor, which serve as docking sites for associated STAT proteins. Upon docking, the activated receptor-associated JAKs phosphorylate STATs. The phosphorylated STATs then dissociate from the receptor chains, dimerize with each other, and translocate to the cell nucleus, where they activate gene transcription. Understanding of this vital JAK-STAT signal transduction pathway has led to the development of orally administered small molecule JAK inhibitors for the treatment of IBD. JAK inhibitors bind to the kinase domain of JAK and prevent its activation, thereby preventing STAT phosphorylation and translocation to the nucleus to activate gene transcription. JAK inhibition potentiates downstream inhibition of cytokine synthesis by reducing the production of pro-inflammatory cytokines. An important example of the effects JAK inhibition can have on reducing inflammation is the prevention of the pro-inflammatory cytokine IL-17 from being produced by T helper 17 cells, even when in the presence of IL-23 stimulation. Ultimately, JAK inhibition can impact multiple cytokine pathways by utilizing small molecule inhibition, which offers the potential for oral dosing and the ability to modulate the extent of cytokine inhibition during a dosing period.
Application in nursing. The action of USP18 result and mitigate interferon-mediated inflammation and is lethal during the perinatal period.
My name is Dr. Rafaela Goldbach-Mansky, and I'm Chief of the Translational Autoinflammatory Disease Studies section at the Laboratory of Clinical Immunology and Microbiology at the National Institute of Allergy and Infectious Diseases.
My name is Dr. Gina Monteledi. I'm a pediatric rheumatologist by training. I do work at the Translational Autoinflammatory Disease section led by Dr. Goldbach-Mansky at the National Institutes of Health.
In the paper, we are summarizing data from a compassionate use program treating patients with two rare genetic diseases, CANDLE and SAVI, with a JAK1 and JAK2 inhibitor, baricitinib. CANDLE is caused by loss of function mutations in genes that encode proteasome components, which assemble recycling units for proteins that are marked for degradation. Patients present with fevers, rashes, inflammation in the fat, as well as muscles and chronic pain. Many of them also develop metabolic syndrome that manifests itself as with hypertension and hepatic steatosis. SAVI is caused by mutations in TMEM173, a gene that encodes viral sensor and adapter that, when activated, leads to the production of type 1 interferon or interferon beta. They present with cold-induced vasculitis, loss of fingers, and with progressive interstitial in the blood that suggests chronic upregulation of interferon signaling. We therefore hypothesized that treatment with agents that target the interferon signaling may lead to amelioration of the disease. In 2011, when we needed to treat a sick patient with candle, drugs that block interferon signaling had not been approved by the Food and Drug Administration. We were lucky to obtain baricitinib,
Pros and cons. Exon sequencing with identified homozygous mutation at essential split site USP18.
So JAK inhibitors are a class of agents. They're oral agents. There's probably at least a dozen that have been in clinical development. And what they do is they potently inhibit a signaling pathway that's overactive in patients with myelofibrosis that contributes to the inflammatory cytokine milieu that mediates a lot of the symptom burden that we've been discussing, whether it's bone pains or inflammatory symptoms like fevers and night sweats. So much of the symptom burden that is part and parcel of having myelofibrosis is driven in large part by JAK-STAT signaling. And these small molecule inhibitors abrogate that signaling and reduce in a very potent way the inflammation that is mediating those symptoms.
JAK2 inhibitors are the only approved form of therapy for myelofibrosis. JAK-STAT signaling is a signaling system in the cell that is associated with proliferation of the cells, lack of interference with the death process of the normal cell, and production of a variety of cytokines. Not surprisingly, the JAK-STAT system seems to be activated in patients with myelofibrosis, regardless of the mutation. By the way, it can be a calreticulin mutation, it can be MIPL mutation, and it can be JAK2 mutation. All of those activate the JAK-STAT pathway and result in increased proliferation of the cells and increased production of a variety of cytokines. This overproduction of cytokines can explain a lot of the symptoms of the patients. Night sweats, weight loss, fatigue, and even anemia. Many of those can be explained.
ISO applied to Ecuador. The case of a child who had inherited complete deficiency of USP18 and survived will beyond the perinatal period due to superior care. Rapid genetic diagnosis by complete exon sequencing and immediate link with the JAK.
There have been a number of preclinical studies using human cells in the test tube using experimental animal models that have indicated that JAK1 and JAK2 are potential targets for intervention in prevention and treatment of graft-versus-host disease. Based on the preclinical and clinical studies, the REACH1 trial was designed and recently concluded, reported in the literature, and the use of ruxolitinib was approved by the FDA. 49 patients with acute GVHD that was steroid refractory. The response rate at day 28 was 54.9%, and many of these patients survived, among those that we never thought could actually have a return. So advanced and so life-threatening their graft-versus-host disease was. Since there are no other drugs that are FDA approved for treatment of steroid refractory or dependent GVHD, the REACH1 data is practice changing. And we have all started to use ruxolitinib for treatment of patients that are steroid refractory. The starting dose of ruxolitinib is 5 milligrams by mouth twice a day. If after 3 days we don't see toxicity, we can increase the dose to 10 milligrams twice a day.
Conclusion. regalemen training was followed by rapid and sustained
We're
recovery.
at ASCO 2011, Professor Alessandro Vanucchi. He is from the University of Florence in Italy. Thanks for joining us, sir.
It's a pleasure.
Let's talk about the Comfort 2 trial. You presented some data here. What can you tell us about it?
Comfort 2 is a randomized trial of the JAK inhibitor INC424 in patients with myelofibrosis. The trial was designed in order to evaluate the activity of the drug against some of the major clinical complaints of these patients that are represented by splenomegaly and by a constellation, a variety of symptoms that affect the patients and affect their quality of life. So this was a randomized trial of the active drug INC424 against best available treatment. That means what the physician thought patients at that time. And in this trial, we enrolled patients with advanced forms of myelofibrosis that are categorized as being at high or intermediate to risk of the disease. That means, in a few words, that their expected lifespan is less than 3-4 years. So in this trial, it was shown that the primary endpoint that was represented by a reduction of the spleen volume available